The hospital discharge bag costs less than $7 to manufacture. 2 small cans of premium infant formula, a branded cooler pack, a stack of coupons, and some promotional literature, all tucked inside a tote bag printed with a pharmaceutical company's logo. A nurse hands it to a new mother on her way out the door. It looks like a parting gift, a small gesture of institutional care from the people who just helped deliver her child. To the corporation that manufactured it, that bag is not a gift. It is a customer acquisition tool with a documented return of $2,000 in the first year alone. And the most efficient part of the entire operation is that they convince the hospital to hand it out for them. This is the story of that bag. What it sets in motion inside the hospital room, what it costs the families who open it, and why the one international code written to stop it never became American law. When a family leaves the hospital with a newborn, they are running on almost no sleep and relying heavily on the judgment of the medical professionals around them. If the hospital provides something, medication, equipment, a bag of supplies, the natural assumption is that someone with clinical authority selected it. That assumption holds for nearly everything in the hospital. The IV drip was prescribed by a physician. The pain medication was reviewed by a pharmacist. Every object that passes through a patient's hands has been filtered through medical oversight. The diaper bag feels like part of that system. It arrives in the same room, handed over by the same staff during the same stay. The brand on the bag, Similac, Enfamil, carries the implicit weight of institutional selection. Parents naturally conclude that the hospital chose this formula because it was the best option for their baby. That conclusion is reasonable. It is also wrong. The hospital did not choose the formula based on nutritional superiority. In most cases, the hospital did not choose the formula at all. The brand in the supply closet is there because a corporation won a government bidding war. The bag in the mother's hands is there because a marketing team calculated that the clinical setting would bypass the consumer skepticism a direct advertisement would trigger. And the paperwork inside the bag, the QR code, the loyalty program sign-up, the coupon requiring an email address, is there because the hospital room is the starting point of a data pipeline that follows the family home. None of this is hidden. The economics are public. The government contracts are documented. The privacy policies are written in plain English. The system works not because it is secret, but because the hospital room is the last place a parent expects to encounter a sales funnel. To be clear, infant formula is a safe, well-regulated, and frequently life-saving product. The question is not about the product. It is about the pipeline that delivers it. We have examined this dynamic before. In our analysis of baby-safe laundry detergent, the mechanism was a single, unregulated phrase on a label, borrowing authority it never earned. Here, the mechanism is not a phrase. It is the hospital itself. The economics of the discharge bag are precise. The physical contents, a few cans of ready-to-feed formula, an insulated cooler pack, promotional inserts, cost the manufacturer less than $7 to produce and distribute. If the family transitions to that brand and purchases it at retail for 12 months, the annual expenditure reaches approximately $2,000. Had they chosen a store brand formula instead, one meeting the exact same FDA nutritional requirements, they would spend roughly $700 less over the same period. The bag does not need to convert every recipient. It needs to convert enough to justify the marginal cost. And the conversion rate is extraordinary. Research consistently demonstrates that parents who receive a branded formula sample in the hospital overwhelmingly purchase that same brand at retail. The anchoring works, even when the bag contains no formula at all, just the logo, the coupons, the branded tote. The medical setting does the persuasion, but the bag does something more consequential than establishing brand preference. It disrupts a biological process. In the first 72 hours after birth, a mother's milk production operates on a strict supply and demand cycle. The infant nurses frequently, and each session signals her body to increase output. This cycle is fragile, time-sensitive, and easily interrupted. When a ready-to-feed bottle sits on the nightstand, pre-mixed, requiring no effort, and the baby is crying at 3 a.m. during a normal cluster feeding period, the path of least resistance is obvious. The moment the infant drinks the formula, two things happen simultaneously. The baby is satiated and sleeps longer, missing the nursing sessions that stimulate the mother's supply. And the mother's body, receiving no signal to produce, begins to reduce output. The supply drops. The deficit becomes real. The family purchases more formula. Population data from the Pregnancy Risk Assessment Monitoring System confirms the pattern at scale. Among nearly 4,000 women who had initiated breastfeeding, those who received commercial discharge packs were significantly more likely to stop exclusively breastfeeding before 10 weeks. The critical word is exclusively. Many of these mothers continued some breastfeeding. What the bag specifically destroyed was the exclusivity, the uninterrupted demand cycle that builds long-term supply and confers the most significant immunological benefits for the infant. The $7 bag did not just sell formula, it manufactured the need for it. If the formula in the bag measurably undermines breastfeeding, the question is why medical professionals keep handing it out. The answer begins not in the maternity ward, but in a government procurement office. The Special Supplemental Nutrition Program for Women, Infants, and Children, WIC, is the largest purchaser of infant formula in the United States. Over half of all formula consumed in this country flows through the program. Federal law requires each state to award an exclusive contract to a single manufacturer through competitive bidding. The winning company offers a massive rebate, sometimes 85% of the wholesale price, back to the state. This looks like effective government negotiation. The state saves billions, the manufacturer takes a loss on WIC-purchased product. Everybody benefits. Except the manufacturer is not taking a loss. The manufacturer is making an investment. When a state awards its WIC contract to Abbott, every hospital in that state stocks Similac. Not because Similac is clinically superior, because WIC-eligible mothers need the contracted brand available at discharge. Once Similac occupies the supply closet, it becomes the default for every patient, WIC-eligible or not. Middle-income and high-income families observe the same brand the hospital uses, conclude it was selected on the basis of quality, and purchase it at full retail price, where no rebate applies. The USDA's own Economic Research Service documents this dynamic. They call it the spillover effect. When a state switches its WIC contract from one manufacturer to another, the new brand's retail market share surges, not because the formula changed, because the hospital changed its inventory. When Texas transitioned its WIC contract from Abbott to Mead Johnson in late 2022, hospitals across the state swapped supply closets virtually overnight. A pediatrician in Houston recommending Similac in September was recommending Enfamil by November. The science did not change. The invoice did. Internal communications show how the companies approach every hospital touchpoint. In a campaign to lock down neonatal intensive care unit contracts, an Abbott Laboratories directive told employees it was time to open up a can of whoop-ass against rival Mead Johnson. That is the language reserved for the NICU, the ward caring for premature infants fighting for survival. The maternity ward discharge bag is a quieter front in the same war. The nurse who hands over the bag is not a willing participant in any of this. She is an overworked professional, navigating a supply chain she did not design. The brand in the bag was placed there by a bidding war. The medical authority that makes it persuasive was never consulted. How a pharmaceutical company legally obtains a newborn's date of birth, tracks their developmental milestones for years, and times its advertising to the exact moments a mother is most sleep-deprived. That story starts with a QR code inside the bag. Programs like Similac Strong Moms and Enfamil Family Beginnings are presented as parental support networks. Coupons, developmental milestone emails, free photo books. To enroll, a parent enters their email address, their mailing address, and their baby's exact date of birth. The terms of service explain what happens next. Abbott's MySimilac Rewards program authorizes the company to collect the baby's birthday, the parent's content browsing activity, and, their language, any inferences that may be drawn from such information. Nestlé Health Science's privacy policy states that they sell or share personal information with data analytics providers, advertising vendors, and social media platforms. The baby's date of birth is the critical variable. It tells the company precisely where the child is developmentally. Growth spurts occur at predictable intervals. Sleep regressions follow a known chronological pattern: 4 months, 8 months, 12 months. Each regression represents a period of parental exhaustion and uncertainty. Each one is a selling opportunity. The World Health Organization documented the scale of this targeting in 2022. Formula companies deploy algorithms that deliver personalized promotions timed to developmental milestones, posting content on social media up to 90 times per day, reaching 229 million users globally. The targeting is not random. It is built on data that started with a registration card inside a hospital bag. The hospital bag data harvesting model has already been tested to its legal limits. In the United Kingdom, a company called Bounty built its entire business on distributing free sample packs to mothers directly on maternity wards. Mothers filled out paperwork at the bedside. Bounty collected the records of over 14 million mothers and babies, then sold them to credit reference agencies and marketing firms without adequate consent. In 2019, the UK's Data Protection Authority fined the company £400,000. The mechanism, using the hospital room as a point of data capture, was not theoretical. It had been executed at massive scale, litigated, and ruled illegal. In the United States, federal law prevents formula companies from accessing hospital patient records directly. The bag, with its QR code requiring personal information to unlock a coupon, is the legal workaround. It converts a protected medical record into a voluntarily surrendered marketing profile. The global health community did try to stop this. In 1981, the World Health Assembly adopted the International Code of Marketing of Breast Milk Substitutes. The code is unambiguous: no free samples to mothers, no promotion of formula in healthcare facilities, no use of medical staff to market commercial products. 118 countries voted to approve it. The United States cast the sole dissenting vote. Since then, the 6 largest formula manufacturers have spent over $180 million lobbying the U.S. government to ensure the code's protections never become American law. The money flows through trade associations like the Infant Nutrition Council of America, which represents Abbott and Reckitt, the same corporations whose products stock the maternity wards. When individual states attempt reform, Texas legislators have introduced bills prohibiting healthcare providers from distributing free formula samples. The industry mobilizes to kill the legislation, reframing a public health measure as an attack on consumer choice. The influence extends well beyond domestic borders. When the government of Thailand drafted legislation aligning its marketing laws with the WHO code, the United States government intervened at the World Trade Organization, pressuring Thailand to weaken the restrictions in order to protect American corporate export interests. Thailand capitulated. In 2023, The Lancet published a 3-part series examining the formula industry globally. The journal's conclusion was direct. Formula companies systematically manipulate science, exploit parents' emotions, and deploy covert lobbying through trade associations to maintain a $55 billion industry at the direct expense of infant health and women's rights. Some progress has been made domestically. The Baby-Friendly Hospital Initiative, which requires participating facilities to ban commercial formula distribution, has expanded in recent years, but only about a quarter of U.S. births occur in baby-friendly hospitals, and even in states where these designations are common, the supply chain overwhelms the policy. A 2025 Texas WIC Feeding Practices Survey found that nearly 60% of mothers whose babies received only breast milk at discharge still reported receiving free formula samples from the hospital. The plaque is on the wall. The bags are still going out the door. The same companies that market freely inside American maternity wards operate under strict advertising bans in the United Kingdom, Germany, and Australia. The formula is the same. The corporation is the same. The regulation is not. The industry's most credible defense of this practice has nothing to do with data or lobbying. It centers on the mothers who genuinely need formula and whether removing the bags causes harm. That defense deserves its strongest version. The United States has no universal paid maternity leave. Millions of mothers return to inflexible hourly jobs within weeks of giving birth, often without access to a private space to pump. For these women, exclusive breastfeeding for 6 months is not a biological failure. It is a structural impossibility. Removing free formula from the hands of a struggling family under the banner of promoting breastfeeding punishes the mother for systemic failures she did not create and cannot fix. This argument is emotionally powerful and factually grounded. The labor conditions it describes are real, widespread, and devastating. But the argument contains a sleight of hand. The bag is not charity. It is a customer acquisition cost. The $7 of product inside it initiates a $2,000 annual expenditure on premium formula that is nutritionally identical to store brands costing $700 less per year. The bag does not help a low-income mother afford formula. It anchors her to the most expensive version of it. Meanwhile, WIC already provides formula at no cost to income-eligible families. The hospital bag is not the safety net. WIC is the safety net. The bag is a marketing layer placed on top of it, engineered to capture brand loyalty and maximize lifetime revenue. If hospitals genuinely aim to support mothers who need supplementation, they could provide unbranded formula from the hospital pharmacy, the same way they dispense every other medical supply. What they provide instead is a corporate tote bag containing premium samples, coupons, and a registration card that funnels private data into an advertising pipeline. The product is essential. The pipeline is not. The system has 4 interlocking parts, and each one depends on the others. The bag enters the hospital because a government contract made one manufacturer the default supply. The nurse hands it over because the supply chain offers no practical alternative, and the institutional setting makes it look like clinical care. The mother opens it because she is exhausted. Her milk has not fully transitioned, and the branded can on her nightstand carries the implicit authority of every clinician she saw during her stay. And the moment she fills out the registration card for a coupon, the company knows her baby's age, her browsing patterns, and exactly when to target her next. No single actor in this chain set out to undermine a mother's breastfeeding or harvest her newborn's data. The nurse is overworked. The hospital administrator is managing a budget. The WIC program is trying to save money. The formula itself is a safe, well-regulated product, but the pipeline connecting all of them was engineered by companies that spent decades ensuring no regulation would interrupt the flow, from hospital room to household budget to advertising algorithm. Each link in the chain is performing its individual function. The outcome, a parent paying premium prices for formula she may not have needed, from a brand she did not choose, tracked by a company she did not knowingly agree to share data with, is not a system malfunction. It is the system performing exactly as intended. The critique here has always been aimed at the pipeline, not the product. And understanding the pipeline is what gives you the ability to navigate it. At the systemic level, the solution is not a mystery. Other countries have already implemented it. Federal adoption of the WHO code would prohibit branded formula marketing inside healthcare facilities. Reform of the WIC single-supplier system, through legislation like the proposed Infant Act, would break the monopoly that turns every hospital supply closet into a corporate distribution point. Expanding the baby-friendly hospital initiative with real compliance enforcement would close the gap between the plaque on the wall and what actually happens in the postpartum room. Those changes require political will that does not currently exist. At the individual level, the single most protective action costs nothing. Do not give the formula company your baby's birth date. That one data point, entered through a QR code, a registration card, a loyalty program sign-up, powers every targeted advertisement that follows you home, every milestone email timed to a sleep regression, every promotion that arrives at 3 in the morning. It all starts with the date of birth. Leave the registration card in the bag. If your baby needs formula, for any reason, Know that the FDA requires every infant formula sold in the United States to meet the same nutritional baseline. Store brand formulas meet those standards. The difference between a store brand and the premium product in the discharge bag is the label, the marketing budget, and roughly $700 a year. And if you are planning a delivery, facilities with the baby-friendly hospital designation have committed to keeping commercial formula marketing out of the postpartum room. Only about a quarter of U.S. births occur in these hospitals, but the number is growing and the designation is searchable online. For families on tight budgets, the practical floor is this: take the formula if you need it, leave the paperwork behind. The product in that bag is worth $7. Your data is worth far more. The hospital room is supposed to be the one place where commercial interests stop at the door, where the people around you are working for your health, not for a quarterly earnings report. The discharge bag breaks that boundary. It turns a place of trust into a point of sale, at the exact moment a family is least equipped to recognize what is happening. Every other developed nation examined this practice and banned it. The United States spent $180 million keeping it legal. Your baby's first hours should not be someone else's customer acquisition strategy. What else have you assumed was protecting your family that turned out to be protecting a profit margin?